Hello again, everyone. Dr. Wiseman here. This is the start of the part two of two video series on Chapter 23, the respiratory system. So let's pick up where we left off from last time. So last time we left off where we were talking about Boyle's law. And again, I told you to not worry too much about these formulas. They would all make sense if we were if formulaic sort of things were part of our clinical paradigm, but really it's just more about awareness. So again, understand that concept. That is, if you have a given number of gas molecules, a given number of moles, if you will, if you want to go into the chemical side of things, if everything stays the same except for volume, when you change the volume is inversely related to pressure. That is, as volume decreases, pressure increases. And again, what's pressure? Pressure is molecules bouncing off the walls of the container. How often are those molecules imparting force on that container surface? So if we were to go the other direction and increase the volume, the overall pressure would decrease. So it's an inverse relationship. A little bit of an aside, but pressure when we're talking about gases is synonymous with concentration. That's the little secret that nobody ever really talks about enough, is that pressure and concentration are basically one and the same when it comes to gases. And we have talked about this before when it comes to that negative intrapleural pressure, that the lungs must be able to change shape. They must be compliant. That is, the ability to be stretched and to be extended, or what we call elastic, which is the ability to shrink in size, return to something. So think about a rubber band. A rubber band is both compliant in that you can stretch it, but it's also elastic in that you can return it to its original shape. A piece of chewing gum that you've been chewing on may be compliant. You can stretch it, but it's not going to return to its original shape. And so this picture right here that just came up, it says it's like a balloon on the end of a straw. Now, the mistake you would make here is that the force causing the balloon to enlarge or shrink is due to the gas moving in. See, when I think about it, I think about blowing gas into this balloon and then it gets larger. But what's actually happening is that we are enlarging the chamber in which the balloon is located. So we enlarge the chamber and that causes a drop in pressure in balloon, and then the air follows suit. So don't make that mistake that the air is causing the lung to change shape. It's actually the pulmonary cavity, and then the air comes in to equilibrate. So when the pressure is low, this is you can see this. Note the relative size of the ellipses here. So when the pressure is low, the lungs are expanding. That means that we're going to move from high pressure in the atmosphere into the lungs. When we reduce the lung volume, and this is where we have elastance, so this is compliance up here, and this is elastance down here, the lungs shrink in size as the pleural cavity diminishes, pressure rises, and the air flows out. The next few slides are going to demonstrate the various ways in which we can change the size of the pleural space. Again, we have to change the size in order to change the pressure in order to allow for air to move. Now, we do have very different ways of breathing in terms of ventilation. We have different muscles that we can use, and we have different ability to move hugely different amounts of air depending on metabolic need and so forth. One paradigm that is the most common is what is known as diaphragmatic breathing. Then diaphragmatic breathing means you're using a skeletal muscle, although involuntarily controlled when you're not thinking about it. It is nevertheless a skeletal muscle that regulates something that is known as tidal volume, Tidal, tidal, like the tide in the ocean. And that's about half a liter. So about the size of a regular bottle of soda that you get, at in Schweitzer Hall. So it's about 500 milliliters, half a liter. And how does that diaphragm do its thing? The diaphragm does its thing by contracting when you inhale. So what happens is it's normally when it's in relaxed, it's actually deviated upward, and the whole chest cavity is reduced in size. But when that diaphragm contracts, it flattens. It becomes more tense across here, and it flattens, and that's basically pulling the lungs and the pleural space down. So we're pulling the pleural space, which in turn pulls the lungs. Remember that that space in between the pleural wall and the lungs is subatmospheric, keeping that lung maximally inflated. So as we flatten that diaphragm, the pressure, the volume increases. You can see the original volume that's dotted here. The volume increases, the pressure drops, and the air comes in to equilibrate. And so when we exhale or expire, if you will, what happens is we get a combination of elasticity, that is the elastic connective tissue surrounding the chest wall recoils back to its original volumetric configuration. The diaphragm relaxes, which means that it deviates upward like so. And so the volume inside the chest cavity decreases. The pressure just for a split second increases and then rushes out of the airways, if allowed, to equilibrate with the atmosphere. So, what I described to you in the previous two slides was what we call passive, relatively passive, quiet breathing, tidal volume breathing, which is about half a liter, about 500 milliliters. We have other muscles that include the intercostal muscles, accessory muscles, abdominal muscles, scalenes, sternocleidomastoid, a whole bunch of other muscles that allow us to move the entire rib cage in order to create much larger volumes, what we would call active breathing. That is voluntary most of the time. It's not entirely voluntary. It can happen on its own. In fact, about 1 in every 5 or 6 breaths or so is actually, you can kind of hear me breathing here, a larger, deeper breath. And that is believed to be in part to help maintain the subatmospheric pressure between the lungs and the chest wall. So you breathe in a little bit more, and that happens automatically. Yawning is sort of in that same boat as well. There is some hypotheses that deep breath that you take when you yawn is helping to maintain that subatmospheric pressure in the lungs. So here we have the rib cage over here. When we use those accessory muscles, the rib cage is lifted mostly up, but also a little bit out. You can see the original configuration dashed here. This rib has moved up, and this tip has actually moved out and away. There's a little bit of cartilage here, allows for a little bit of stretchability. The rib cage does have some compliance. We talk about compliance for the lungs, but the rib cage has compliance as well. And you can have too much compliance or you can have too little. So I have this is just a water pump, and you can see if you were to put a line here that when we move that handle is certainly moving up, but it is also moving out. So we're increasing the volume three-dimensionally, if you will, lifting the sternum, lifting the ribs, and the ribs sort of swivel out, and that increases volume. And just another view of the same thing. This is looking from the front where you see the ribs have been lifted up, the sternum has been lifted out. And again, this analogy, and I've put the lines in here. So when we have the ribs in the exhaled position, it's this far away from center line, but when we lift that handle up there, it's further away. It's just the same story as previous slide. Now this graph is not from your book, but I think it shows graphically what we've been talking about up to this point. Now, I kind of need to break this graph out for you. So we have how much volume you're moving, whether you're inhaling or exhaling here. And this is tidal volume. You can see the number there is 500. That's 500 milliliters. Now, on typical inhalation, A typical respiratory or a ventilatory cycle begins at the bottom of a normal breath where you have exhaled. So you see where my pointer is right now, that's the beginning. And so a typical ventilation cycle is inhale and then exhale. So we start at the end of an exhalation and we inhale and we exhale. That's one graph here. And you can see this is on time here. You can see it's on time. This up above is showing you the pressures involved, whether it's in the lungs in red. So this is alveolar pressure. This is the pressure inside the air spaces of the alveoli. And you can see that as we inhale, so let's look here, we're inhaling here. This is all in the same x-axis. As we inhale, the pressure is dropping, and that's causing a movement in air. You can see that as we begin dropping, the air begins moving in, and then we hit peak inhalation here. This is regular tidal volume. And then as we begin to exhale, pressure rises. So the pressure has to rise in order for the air to move out. The pressure has to fall for the air to move in. Now, what's this blue line here? This blue one is intrapleural pressure. This is the pressure outside of the lungs, but inside of the chest wall. And it's the same graph. It's on the same X and Y axes. So you can see here that we have alveolar pressure, and then intrapleural pressure is about 1, 2, 3, sometimes a little more than 3, maybe 4 millimeters of mercury lower. So as we increase the volume, the pressure drops, volume moves in. As we increase the pressure by decreasing volume, the pressure rises and air moves out. It is showing you where we're measuring pressure all at the same time, whether it's the amount of air that's moved, this is called a spirometry measurement, and the overall pressure inside, whether it's the space between the lungs or the space inside the lungs. And between the lungs and the chest wall is always about 3 to 4 millimeters of mercury lower in order to keep that lung maximally inflated. And we've talked about all of these things a little bit, but let's kind of put these things together when it comes to the variables that affect ventilation. The ability to ventilate, the ability to create gradients that facilitate diffusion. We're not really getting into gas exchange here per se, but we are getting into setting up the conditions for gas exchange. And the 4 variables, we've talked about all of these to some degree or another. Compliance, that's the ability to stretch and distend. Elastance or elasticity, that's the ability to return to your original shape following being stretched or distended. Surface tension, we'll get to that a little bit. We're going to we're going to define that a little bit more, because let me just give you a head start on this. Those alveoli are really, really small, and there are millions of them. And if you were to look at a piece of lung tissue in your hand, it would sort of feel like a sponge. And you know how you take a sponge when it's dry and then you can run it under some sink water and it fills up with water and gets saturated? That can happen in your lungs too. And that is due to the surface tension of water. So that surface tension of water is too high for the lungs, so we have to deal with it somehow. So we're going to talk about that. So surface tension. And then lastly, resistance. The number one thing with resistance is diameter of the conduction airways. A lot of the times we talk about it in terms of pathology, but as I mentioned, we can use resistance in order to shunt or move air differentially in the lungs. Like for instance, let's say you get an object stuck down here where my pointer is. It doesn't make any sense to send air or blood to that little area because the air has been cut off. So there are some resistance issues that way. And then, like I said, resistance issues in terms of COPD and asthma and things along those lines. So we're going to get to all this stuff. Okay, so Digging deeper into the definitions, giving you some examples clinically. The first variable is compliance. That is the stretchability. We've talked about this before, but I want to just reiterate it and then put it into some clinical context. Under normal circumstances, your lungs will have a sort of a, if you look down at the alveolar structure, almost like a grape cluster shape. And that's in order to maximize surface area and interface with the bloodstream. But in cases of pulmonary fibrosis, you can begin to see there's certainly some alveolar destruction here. But the number one thing, even if the alveoli are in place, is that the lung has a more difficult time changing volume. That is to say, it has less compliance. Less compliance means less stretchability. Now, we could talk about your lungs. You could also talk about the chest wall as well. There are issues where you have low compliance when it comes to the chest wall. And this low compliance, by the way, of the lungs is actually why when you see smokers, chronic smokers, they have a sort of a barrel chest. And part of the reason they have that is from the fact that they're having to use accessory muscles in their chest much, much more often than somebody with a nice healthy lung. They're having to work so much harder on a moment-to-moment basis over years and decades in some cases, that their chest morphology actually changes. They get kind of a barrel chest. So it's how well the lungs comply to a change in volume. And again, compliance applies to lungs. It can also apply to ribs and the chest wall as well. We aren't going to get into too much in terms of premature infants and so forth. We'll talk about it when it comes to surface tension. But one of the things that happens in a premature child is that the chest wall hasn't fully ossified, the bones in the rib. And so when they breathe in, the chest deflects in. Same thing's true with somebody who has what's called a flail chest. A flail chest is where you have multiple fractures and multiple ribs, and when they try to breathe in, that reduction in pressure causes the wall to buckle inward rather than expand outward like it should. But again, compliance is that stretchability, and for our purposes, we're going to stick mostly to the lungs. So if compliance is the stretchability, the ability to comply to a change in volume, then we have elastance, or you could just say elasticity. They both mean the same thing. That's the ability to recoil, and that's due to the elastic connective tissue that's found in the alveolus. Even the muscles in the bronchioles can actually have a little bit of recoil as well. They contract ever so slightly during exhalation. So elasticity, that ability not, so compliance is the ability to stretch, elasticity is the ability to return. If we look at an original alveolus here, you can see this nice grape cluster. Then the membrane around it is actually resembles what the alveoli look like in cases of emphysema. Emphysema fundamentally is a loss of surface area. You don't see those lovely grape-like structures. You see these large extended pouches. There's actually, even though the pouches, that alveolus is larger, nevertheless, the surface area is greatly diminished. So in emphysema, you have a loss of surface area, but you also have a loss in elasticity. People with severe emphysema, you'll often see, will breathe with their lips pursed. They'll breathe out. I'm doing it right here, with their lips pursed in order to increase the pressure inside the lungs as they exhale, because they are at risk of pneumothorax and alveoli collapsing. And then if they collapse, and then you go into a hypoxic crisis. So they begin pursing their lips as they exhale in order to keep this sort of stretchy but not elastic lung chamber open. Our third variable is surface tension. And again, we could go down a rabbit hole here, but we're going to just kind of summarize it a little bit. If you remember, if you've taken a cell biology class, or if you've had 165 here at UND, You will remember that water has two properties. One is adhesion, which water can adhere to another surface like this droplet here. So it has adhesion, but it also has cohesion. That is, the water molecules stick together. And this is why, if you take, I said, you take a sponge and you put it under a sink or a faucet, it'll fill up with water. That capillary action that a sponge can do. This drop right here on this finger is many, 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 many times larger than the alveolus, the volume of an alveolus or alveoli. And if left to its own devices, the alveoli would act like a sponge because of surface tension. If you have a small radius test tube, just a little bit larger than a dime, you can actually take a dime and float it on the surface of the water due to the surface tension. To make a long story short, the smaller the diameter, the higher the surface tension. So the larger the diameter, the lower the surface tension. And so since airways and alveoli are very, very small diameters, they have high surface tension. So your cells in your lungs and your airways secrete a mixture of substances called surfactant. It's mostly lipids. It includes a few proteins, including a little bit of mucin in there as well, and some ions and water. And that creates a thin film along the inner surface of the alveoli and the airways. So it maintains moisture there, but it doesn't form droplets like this. It breaks up the surface tension. And so you can look up cystic fibrosis, and that's an issue there where you have issues of surface tension because you're not moving enough material to the surface of the airways, and the material that you do get there is very thick and doesn't break up the surface tension. So surface tension is breaking up so that you can have a thin film of water. It breaks up that surface tension, surfactant. If you don't deal with this, what can happen is that you get disorders that then where you have fluid buildup, or in some cases actually injury to the lungs. The problem is that what happens is you can't maintain air spaces in this tissue, and in some cases you can cause irritation and injury and tissue destruction if you don't have surface tension inside the lungs managed properly. This is true in premature infants. The premature infants, usually before 24 weeks, don't secrete surfactant in their airways. The lungs haven't matured enough to where the surfactant is being released. And so artificial surfactant has been the number one reason for why the age of viability has diminished in premature infants. That is to say, 24 weeks was absolutely off the table, 30 or 40 years ago. And now it's almost routine. Now we're getting, less than 24 weeks, 20 weeks in some rare cases. The survivability is so rare. But part of the reason why we have pushed the barrier of viability is due to the fact that you can apply artificial surfactant in order to allow for the breakup of water droplets and creating a nice even film across the airways and in the alveolus. If you don't, the water fluid will build up. You can get lung collapse. You can certainly get lung injury. Premature infants lack surfactant, but it turns out that people who suffer from smoke inhalation have surfactant problems, where you have acute lung injury, and extremely old people sometimes have surfactant issues as well. Talking about centenarians, people that are 100 plus years old, begin losing that ability to secrete, and so they start to have lung issues. And so we've covered compliance. We've covered elastance or elasticity, that recoil, that rebound. We've talked about surface tension. There is actually a mathematical formula called the law of Laplace that describes surface tension. We don't have to know that. You just have to understand the concept of surface tension. And then finally, our last variable is resistance. That is the friction that is caused by fluids or gases moving through conducting pathways, whether they're pipes or airways. And the person who described resistance actually was a contemporary of Louis Pasteur a few 100 years ago. Pasteurization, you've heard about that. And what resistance is that if you change some certain variables, you change the friction and the resistance for gases or fluids to flow through. Let's take a look at these airways. We got three different airways here. First one is a normal airway. The second one is an airway in someone who suffers from chronic asthma, and the third one is someone who suffers from asthma and is having an asthmatic inflammatory attack. You can see here this airway. All right. Now look at the radius here. You can see that the cross-sectional area of even an unstimulated asthmatic airway is significantly smaller. It turns out there are the most important factor in resistance is the radius of the vessel involved. So if the radius drops, it's actually to the fourth power. If you cut the radius in half, that would be 1/2 times 1/2 times 1/2 times 1/2, which would be 1/16 the flow, about 5%, little more than 5% of what the flow is capable of. So it doesn't take a whole lot of change in radius in order to have extreme effects on flow. Never mind when you have somebody that has an inflammatory asthmatic attack. You can see the radius is way shrunk down. They may not be able to move the air at all in this situation. It's called air trapping, where they might get breath in, but then they can't keep ventilating. They can't move the air or they can't move the air fast enough. I'm going to talk about that in a slide later where it's not only volume, but it is also rate of ventilation in terms of how quickly you can move that volume. That's important. So we'll get to that in a little bit. Resistance could also be occurring because of fluid buildup. You can see that the overall, you have a reduction in that sort of a thing. So that's also a potential, in a pneumonia, you're not only decreasing surface area, but you're also increasing resistance to flow. So we have those four factors: compliance, elastance, resistance, and surface tension. Those are the big four. Now let's show you how we can assess some of these things clinically, something that you might see when you're taking care of patients. Here, this is called spirometry. You hook somebody up to a machine that can measure volume. This happens to be an electronic spirometer. There are spirometers have been around for over a century. In any case, what we have here is it's measuring volumes that you move over time. So volume, time. And so we have an inhalation. It begins at the end of the previous exhalation and exhale. That's called tidal volume. And then you can see they can inhale much further and they can exhale much further. So we have some additional reserve volumes on either side of tidal volume. And we're going to classify those and talk a little bit more about it in the following slides. We've already defined tidal volume, and here's the formal definition. It's the amount of air breathed first in and then out in a normal, shall we call it unconscious standard breath. All right. It's weird. Breathing is sort of weird because as soon as you start thinking about it, your breathing changes. And so if you were just sitting in your chair not thinking about breathing, which you can't unthink now, it starts when you inhale. So you use those diaphragmatic contraction and then exhale where you have mostly elastic rebound going on. And that's tidal volume, about half a liter, about 500 milliliters. Almost said a larger number there. Anything beyond a normal inspiration. So here's that 500 milliliter mark, and anything that you can breathe in further, and you can see the scale goes way up. I've seen numbers go all the way up to 6 liters. So you breathe in 500 under normal conditions and you can breathe way up here. And that's called anything beyond a normal tidal volume is known as IRV or inspiratory reserve volume. So this is any volume that you can inhale beyond a normal tidal volume. Now remember that tidal volume is defined by the base of a normal inhalation and expiration. So if we go from the base of a normal expiration and then we breathe further out, breathe out, out, that's called expiratory reserve volume. So anything beyond a normal exhalation is ERV, expiratory reserve volume, inhaling, exhaling reserve volumes. Now, even if you could squeeze every last, thing out of your air out, as hard as you would try, there is always going to be some volume in the lungs. We call it it can be air. It could also be occupied by tissue. We call that remaining air and so forth. We call that residual volume. There's always a little bit of air in there because, again, you're keeping the lungs maximally inflated, even if it's at its minimal volume. All right. So we call that residual volume right here. That's the leftover dead space. And it's not dead tissue. It's just that it's air that cannot be circulated in or out. There are some additional volumes that we call capacities. And there are some inspiratory capacities and some things along those lines. But what a capacity is it's basically the sum of all of the volumes. So if we have tidal volume, we have inspiratory reserve volume, and we have expiratory reserve volume. That's known as vital capacity. It's the sum of the tidal volume plus the two reserve volumes. Vital capacity. Now, if you add in the residual volume, okay, that airspace that doesn't that remains even after the deepest exhalation that you can achieve, we call that total lung capacity. So you might have about, you can see about 1,500 milliliters of residual volume added to that expiratory reserve volume, tidal volume, and then inspiratory reserve volume. You get somewhere, north of 4,500. That actually feels a little bit low. For most people, it's probably closer to 5 or 6 liters. Professional bicyclists tend to have really, really large lung capacities. They're basically lungs with a pair of legs hooked onto them. So when we have the tidal volume, we've got the IRV reserves, ERV reserve. We add those together, that's vital capacity. If we add the residual volume, then that's total lung. And so here's just another figure showing the same thing as before, though this is a little less hand-drawn. So right here we have tidal volume, that 500 milliliters in and out, that sort of involuntary standard breath. If we inhale beyond a normal tidal volume, that's IRV, inspiratory reserve volume. And if we exhale beyond a normal exhalation, that's expiratory reserve. Now, something we didn't talk about on the previous slides, inspiratory capacity is just regular inhalation and IRV, okay? Inspiratory capacity, whereas vital capacity is ERV, IRV, and tidal volume. So it's everything. So we didn't define that before. It's basically just the inhalation of a tidal volume plus inspiratory reserve volume. And here is residual volume, and you have total lung capacity, which is all of the volumes added together. So what happens when we have a problem? What happens to the volumes in the lungs? Well, there's actually two different ways of looking at this. First of all, the volume overall might change. Let's say your lungs fill up with fluid, you don't have as much volume that you can move. Problem, okay? There's also an issue of rate, and that's where resistance comes in. We've already sort of alluded to this, but I'm just going to show it to you in graphical format. So we have the rate at which you can move a volume. So let's look here. This is an experiment where the patient is asked to breathe in as deep as they can and then breathe out as fast as they can. Okay, as fast as you can over 6 to 8 seconds. You can see a big chunk of that volume is moved in the first second. That's called forced expiratory volume 1. Almost 3.5. Let's say it's 3 1/3 liters. A lot of volume there. Somebody with obstructive disorder, like chronic obstructive pulmonary disorder, asthma, um, so forth, pulmonary fibrosis, you can see their FEV1 is almost half of what the FEV1 is in a normal person. They can eventually achieve that volume. It's just that they achieve it slower, and so they can't move air as fast as a healthy patient, and that affects concentrations. That affects concentrations. Their CO2 in their blood goes up, their O2 in their blood goes down. All right. So that's what we call an obstructive disorder. Asthma, pulmonary fibrosis, anything that reduces the or increases the friction, increases the resistance to air movement is going to affect rate. That's an obstructive disorder, very, very common. Then you can change overall volume. So let's look at this figure right here. So here's our normal patient again in green. Here is our obstructive disorder, and you can see that FEV1, forced expiratory volume 1, is greatly diminished. They eventually get to full volume, but they can't move air as quickly as they would like, and that leads to concentration issues. Now let's look at somebody with what we call restrictive disorder, and you can see that they never can achieve the volume. They will never get to that same volume. The volume is reduced. So they can't move the same overall volume. It's not a function of time. Time doesn't matter. You can see that the FEV1 is an issue, but that's neither here nor there. We're talking about overall volume in this case. All right. This is known as a restrictive disorder. A restrictive disorder could be as simple as wearing clothing that's too tight. All right. Take a belt, strap it around your chest and cinch it down. Okay? That's a restrictive disorder. You can't move the volume anymore. So obstructive disorders are caused by blockages in the airway, reductions in the radius of the conducting structures. Choking would be an example of an obstructive disorder. All right, asthma, inflammation, bronchitis could all be considered obstructive. Restrictive affects the capacities, the ability of the lungs to take in air at all. Let's look at some examples of some restrictive disorders. Obesity, for instance. So somebody who is what we call morbidly obese, significant obesity, leads to loss of overall volume in the lungs. Pregnancy, you don't ever think about that, but as that fetus is developing in utero, it's taking more space, which means that the diaphragm can't move down as well as it could outside of pregnancy. So pregnancy is a common cause of what we call restrictive disorder. Flail chest, we talked about that because the lungs can't change volume. The chest wall deflects in. When you try to breathe in, that's a restrictive disorder. Muscular dystrophy, the inability to contract the muscles of the chest wall, so you can't move volume. Or something like pneumonia where there's fluid in there, and so now there's less functional volume. And so if you would like to look further at this is a really, really nice website. I've put a QR code here. This is the URL for that QR code. You can just use your phone and do that. But I recommend you look at it on a big screen. I think it's better on a big screen. But if the phone's all you got or that sort of a thing, that's fine. You can use this QR code to do that. Or just copy and paste the link from your PowerPoint. So you've got download the PowerPoint. You got the link in there, copy and paste it. So in this slide, I have an example of one of the essay questions and show you how to go after this. First of all, you're going to need to be able to understand what compliance is and what it does, how compliance contributes in terms of alveolar function. Remember that when you're writing these things out, they should be in whole sentences and not just restricted to bullet points like this. Secondly, what is elasticity and what does it do? How does it contribute to the function of the alveoli in the lungs? and bring some context in here. Try to keep it simple, but apply to the respiratory system. It is so easy to fall into the trap of talking about materials science or physics for that matter. Don't fall into that trap. It needs to apply to the physiologic respiratory system. It should show that you understand and can communicate the idea of the mechanics of ventilation, how it's doing its thing, how volume changes, which lead to pressure changes, which lead to equilibration. Okay. Whether we're talking about inhaling or exhaling. All right. Link function to action. Link function to action. Alveoli are exchanged. They need to have a gradient. They need to be able to move that air in order to sustain that gradient. Okay, we change volume, we change pressure, we get equilibration. Same for both directions. And then lastly, which part of inhalation and exhalation is dependent on these factors of compliance and elasticity? Okay. Which one depends on compliance? Which one depends on elastance? All right. Try to be reasonable, but also try to be inclusive with your answer. And that's it. We have completed part 2 of chapter 23. Again, as always, if you have questions, please contact me. I am always wishing for students to be as proactive as possible, to not presume, to not just think that you can remember everything and have it in the front of your brain, even if it's something as simple as when we're doing class and so forth. So always check your resources, take your time, and be sure to ask questions. And thank you, and good luck, and I'll talk to you again soon.